to a rheumatologist in the past for a different program, and he thought there was value in the use of ultrasound in a raging case, like to see if what you started with was working, or if sort of to help them decide whether to switch therapy. So that's one. Get your thought on that. The other one, which I thought was interesting, Dr. Strand had a comment that sometimes, given how limited sometimes we are with the imaging techniques and what we can do, she uses it a lot for a particular patient to when she gets a patient type that she doesn't see the need to target. She might get evidence to show the patient this is what is happening. So those are two different imaging related observations.
Yeah, so I can touch on those. I mean, I think that the first question is sort of the idea of using imaging to identify response to therapy. And that, there's not a lot of data there, but that certainly makes some sense. And it's an important question because we remain in an era where our treatment of rheumatoid arthritis is very much trial and error. And we, we tend to start first with methotrexate because it's inexpensive, a percentage of patients will respond, and it's kind of our first move. And in fact, insurance often drives us there anyhow. And then we try, if they fail methotrexate, there are some people still use triple therapy, but many people, even if that's not tolerated or just go straight to biologic therapy. And we really have very little data telling us which biologic to use in that situation. And so it is very much trial and error. You put a patient on a drug, and you wait and see if they respond. And if they don't respond, you try another drug. And if they don't respond, you try another drug. And it's not a very satisfying way to treat a patient. And so there's been a lot of thinking about early markers of response. Are there biomarkers? Are there other parameters that you can identify early on, perhaps as early as 4 to 6 weeks on therapy, that show a high probability of response, or particularly a high probability of non-response, which would, induce you to change treatment earlier as opposed to sort of waiting 3, 4, 5, 6 months to see if they're going to finally, respond. And there's some potential logic and role there for an ultrasound, I suppose, that might identify a patient who has a rapid resolution of, ultrasound findings, or a patient who has persistent raging ultrasound findings. I think that the challenge is that if we're going to make treatment decisions, if we're going to make decisions on changing or not changing therapy based on that, we need the data to show that that's valuable. And I don't really know that we have that at this point. But it's a reasonable concept that needs more data.
Got it.
To Dr. Strand's idea, confidentially between you and me, she doesn't see a lot of patients. So
okay. Yeah, I think she mentioned she sold her practice.
Yeah. She does. She precepts some fellows sometimes. She really doesn't see a lot of patients. So, but she's a smart woman. She knows.
Oh yeah, definitely.
So, I mean, her concept is good, and but you can do that clinically too. So it depends on the patient. So I do the same thing with a rapid 3-score or a clinical disease activity index, where I capture the patient's information, I capture the joint counts and my assessment. I capture acute phase reactant sometimes, and come up with a disease activity score. And I find it's very helpful in many cases to show the patient their clinical response over time. That you can show them a number. It's patients like that. It's like showing them their cholesterol or their hemoglobin A1C. They like something they can point to that says, well, this says I'm doing better, or this says I'm not. And so it's particularly helpful when somebody's doing better because I think it's reinforcing that, what they're doing and the treatment they're taking that they may be somewhat nervous about is doing the job.
Yeah.
But when they're not doing better, it's helpful to show them that, to say, hey, we're not getting anywhere, and it's time to make a change. And I know you're uncomfortable, changing treatment because you are better than you were, but you're still not where we want you to be. And so
right.
I often do that using the clinical data, but I can see that in some cases if you had, ultrasound images or MRI images that you could show them, I think that would be helpful. My personal opinion is I don't know how that is as valuable because those images are a little bit squirrely and they're really hard sometimes to interpret. And so it's
True,
not that easy. I mean, an X-ray is easy. You can show based on an X-ray and say, here's a bone, here's an erosion, here's a piece out of that bone, or here's a joint, and look how this joint is narrower and there's less space between the bones and in this joint. Ultrasound images, MRI images, they kind of look like weather maps. And they're challenging for patients to sort of get. Doppler images can be useful. So Doppler, because of the color, I think that might potentially be useful. You can show them and say, look, here are your joints in your hands, and in fact, see all this, color Doppler signal that says they're still inflamed. And here's a joint where there isn't any, and that's not. And so we need all the joints to look like that one and not like these.
Yeah.
So there's some potential value there for sure.
Yeah. Yeah. Thank you. I think we are very good on that one. And the next one is a patient care perspectives on rheumatoid arthritis treatments and skin cancer. And I thought there was something late breaking, but you guys already knew about it. So, and that makes it even more difficult, right? If all the different therapies have a weak association or whatever, it's hard to tell what's what. But
So when we're treating rheumatoid arthritis, it's interesting, and I'm sure you've heard this and seen this before, is that when, there's that sort of old sort of joke that no matter what the patient asks you, the real meaning of that question is, am I going to get cancer or do I have cancer? Right. That's what they always want. And so potential for malignancy is a huge issue with patients, particularly in this day and age where they have access to lots of data, and they see TV ads that always end with all that horrible list of toxicities that we're seeing in trials or death, and that may or may not be accurate or important in that individual, but they hear about it. And then they get online and they see all this stuff, and they're on focus groups or, on support groups and on listservs and all that sort of stuff where they hear all this story about the potential for malignancy. And people get scared. And I certainly have patients who are reluctant to go on therapies or change therapies. And it's a challenge. On the other hand, it's really important for us to give them good information and not bad information. And so, we are able to now say with pretty solid data that, biologic therapies do not increase your risk for solid malignancies, for the usual things that people are concerned about: breast cancer, lung cancer, colon cancer, prostate cancer, and that brings up a whole nother conversation, in the RA space, because we have to say, well, RA patients do have an increased risk of lung cancer, but that's because they smoke, and they're more likely to be smokers because of the link between smoking and rheumatoid arthritis. And explain all that. Lymphoma is always a challenge because, there's a black box warning and all the TNF inhibitors, and that will always be there, but I think it needs to be put into context, and I think that, I always explain to patients that that was seen in clinical trials, but we now have quite a bit of evidence that would suggest that risk is really disease-related and not treatment-related. That, question about lymphoma showed up in the past with methotrexate and then turned out to be disease-related. And then it's largely based on quite a number of, post-marketing data and registry data that show that it's disease-related, it's disease severity, and that, adding a biologic in fact, may not increase risk of lymphoma, and that by reducing disease activity, it might potentially even decrease your risk, but we don't know that yet, and we haven't shown that yet. Skin cancer is a little bit more challenging, and so whenever you look at trial data, non-melanoma skin cancer is always sort of carved out because it's its own thing, and it's not lumped in with all the other malignancies. It's not captured in large sort of malignancy databases so that you have a comparison. So the SEER database, SEER, which is sort of the large malignancy database that people sort of use as a normative database in clinical trials, doesn't include skin cancers, and so you don't have that background to compare it to. So it makes it a little bit more challenging. On the other hand, there's generally been evidence that virtually everything we use that is immunomodulatory, from methotrexate to leflunomide to azathioprine, and now to basically all the biologics, they all increase your risk of non-melanoma skin cancer, basal cell and squamous cell carcinomas. And that makes some clinical sense because these are all, sun-driven cancers, and if you're doing anything that might disrupt tumor surveillance, then you're going to increase the risk that a cell is going to get affected by too much sun exposure and go bad and become a skin cancer. So it's not a new story for us. It's been a story with methotrexate for years. The challenge with the story too is whether the rheumatoid arthritis itself increases that risk, and there's been some data that says maybe it does, mostly it doesn't, but it's very colored by therapy, which is really hard to split out from that.
Right.
But consistently, all of the trials with TNF inhibitors and other biologics